Hello, everyone, and welcome to the latest program on how NQF members are responding to the challenges around COVID-19. I'm your moderator, Jonathan Sullivan, the Vice President of Product and Membership Design at the National Quality Forum. We're glad you could join us, and we hope it will be an informative session. This program is made possible by you, the members of the National Quality Forum. Members are the driving force behind NQF's mission to advance measurable health improvements. Together, we do the work that enhances healthcare value, makes patient care safer, and results in better outcomes. Members continually demonstrate their shared commitment to the NQF mission through engagement and service, and our presenter today is no exception. Edo Banach is President and CEO of the National Hospice and Palliative Care Organization. He previously was a partner in the firm Gallagher, Avelius, and Jones in Baltimore, Maryland. Prior to that, he was the Deputy Director of the Medicare and Medicaid Coordination Office at the Centers for Medicare and Medicaid Services and Associate General Counsel at the Visiting Nurse Service of New York. Prior to that, Edo was the Medicare Rights Center's General Counsel, and he's practiced law at the firm of Latham & Watkins and clerked for U.S. Judge John T. Nixon of the Federal District Court for the Middle District of Tennessee. Prior to attending law school, Edo worked for the New York City Department of Homeless Services and Mayor's Office of Operations. Mr. Banach holds a BA from Binghamton University and a JD from the University of Pennsylvania Law School. Some quick logistics before we get started. We hope you'll take an active role in the question and answer portion of the program. However, please help us stay on topic and refrain from questions or comments that aren't related to today's information. We have muted the phone lines to ensure that unexpected noise does not interfere with the program. We'll be taking questions both through the web and on the phone lines today. If you're on the web, we're displaying instructions there for how you can ask a question. If you're only on the phone and unable to see the instructions, I will prompt the audience when it's time for phone questions. At that time, you can hit *7 on your phone to unmute your line. When you've asked your question, please mute your line again by hitting *6. With that, I'd like to turn it over to National Quality Forum CEO, Dr. Shantanu Agrawal, to kick off the program. Shantanu, you can hit *7 on your phone to unmute.
Thanks, Jonathan. Can you hear me?
Yes.
Great. Well, I wanted to thank you all again to this webinar, and as Jonathan had pointed out, our latest in a series of COVID-19 related webinars that we've been doing for and with our membership. Your participation as members, both in NQF but also in these webinars, is extremely critical. We hope that through them you are getting access to some of the leading voices in responding to this pandemic and frankly learning some best practices and getting access to resources to help you and your organization respond to everything that is going on. We've had the opportunity, I think, through these webinars to explore a really wide variety of topics. And today I'm really thankful to have a good friend, Edo Banach, here today to share what is going on the front lines of this pandemic in hospice and palliative care, and more broadly than that, in long-term care and nursing home settings. Edo's a really impressive guy. He's a great friend, and I think in addition to just talking about everything that is going on in his organization and in the hospice and palliative care environment, he's really been, I think, he served as a resource, as an expert for the administration, and I think that's very important. He can provide us some insight on how the administration is thinking about these various topics, and of course in a non-political way, as you would expect from NQF, but I think still worthwhile to get that insight and understand where all of this is proceeding. So with that, Edo, I want to thank you for taking the time to come and present here. It's critical to hear voices like yours, and I'll turn it over back to you and to Jonathan. Thank you.
Thanks, Shantanu. Well, Edo, I will turn the program over to you, and I'll advance the slides based on your cues.
Hi. Can everyone hear me?
Yes.
Hi, everyone. It's Edo Banach, President and CEO of NHPCO. First of all, thank you to my friend Shantanu Agarwal. We both served inside of CMS, and I think really feel for our colleagues who are still there and are working tirelessly on the response to COVID-19. And I really wanted to start with that. I think that as we all think about folks who are really under the gun and are stepping up, it is providers, certainly it is families and communities, and it's also the folks inside of CMS that are trying to figure out how to really make a difference, and I wanted to thank them for that. A little bit about NHPCO before we begin, if you can advance to the next slide, please. We, in a sense, were made for this. NHPCO was founded in 1978. It's the nation's largest membership organization for providers and professionals who care for people affected by serious and life-limiting illness. So over 1,000 providers across the country who provide both hospice and pre-hospice palliative care all across the United States. Our mission is to lead and mobilize social change for improved care at the end of life. And our vision is a world where individuals and families facing serious illness, death, and grief will experience the best that humankind can offer. We're at one of those inflection points in our nation's history when we think about how we step up and what we do will often define all of us for years to come. And the fact is that shortly after NHPCO was established, a demo called the Hospice Demo was enshrined. And 5 short years after that, in 1983, that demo became what we know as the Medicare Hospice Benefit. It was an amazing accomplishment back then, but what was even more amazing was how the movement really stepped up and leaned in during the HIV and AIDS epidemic that followed that. The movement, the community could have said, not our issue. This is infectious. We don't know much about it, but didn't do that. It was a moment where the community leaned in as information was scarce and provided to the best of its ability care to people who were seriously ill and dying. And we're at a moment with a very different virus now, but a virus that's unknown, that has no cure, and we have to figure out how to collectively provide care. So I wanted to get into what we're doing, what the government's doing, and then we'll take some questions at the end. So next slide, please. So as I said, we were made for this. Next slide, please. First of all, in light of COVID-19, we have to make sure that folks are getting immediate access to person-centered interdisciplinary care. And so at the very early stages of the pandemic, our immediate concern was on patient and family access to care. Folks who required hospice and palliative care, whether for COVID-19 or not, we wanted to make sure that they were getting that care. And that required, and still does require, a number of different things. And these are things that, as Shantanu said, we've had a couple of opportunities to meet with the White House, and these are things that we stressed to them as well, and that we discussed in detail. One is access to protective equipment. It was, and is less so, but still is, a challenge to get access to sufficient protective equipment. Hospice is often at the end of the food chain when it comes to protective equipment, and even when protective equipment goes to communities, it's often the institutional providers that get access to it first. That's shifting, but it's shifting as a result of advocacy. One, for the use of the Defense Production Act to have more protective equipment produced, and two, advocacy to have hospice and community-based providers be given higher priority. The other major key initiative has been access to tests, and that's not unique to hospice and palliative care, but certainly as providers that for the most part provide care to folks in homes or wherever people call homes. we want to make sure that we don't act as a mechanism for the spread of the disease. We have to protect our workers, and we also have to protect the people that we visit. So it's both a case of wanting to be protected via PPE, protective equipment, and wanting to be tested to make sure that if someone is infectious, that they don't go and make a visit. And so testing has obviously been top of mind as well. And the third bit, and I just want to, and we'll expand on this in subsequent slides, is people get hospice in a variety of settings. When I say home, or a place where people call home, could be a nursing home, could be an assisted living facility, could be an individual's own home. And with assisted living facilities and nursing homes, as we all know, those have been some hot spots of the COVID-19 infections. And we want to make sure that we can still receive adequate access and visitation to folks to provide care, yet at the same time protect the residents of those homes. And we'll get into that in subsequent slides. The next slide, please. Initially, and subsequently have worked with the administration to grant some really important flexibilities under 1135. And these are flexibilities really to the rules of the road that allow providers to provide care under conditions of participation. Some really important flexibilities were granted with respect to telehealth. So as folks know, sometimes it's necessary and, in fact, important to make in-person, face-to-face visits. However, other times it's also possible to make those visits remotely through the use of technology. That was, at least in hospice, very limited. And it's less limited now as a result of legislative and regulatory action. Telehealth, including audio and video capabilities for assessment, for ongoing care, and for eligibility, and also relaxation of HIPAA rules that enable the use of telehealth apps that wouldn't have been possible absent this flexibility. And also flexibility to quality reporting, and this is something that's obviously important in terms of our partnership with NQF. We're not saying relaxation of the standards, but an extension of the time frame for submission of CAPS data and other data as well. Quality is crucial, and we want to make sure that we maintain it even during a pandemic. Next slide, please. And it wasn't just regulatory action that has been secured under the CARES Act. In addition to funding, providers are allowed to use telehealth to conduct the face-to-face encounters during this pandemic. In terms of future legislation, I just want to dwell on this for a second. You know, we talk about individuals who are presenting some symptoms but don't need to be hospitalized, staying in the community, convalescing in place, not clogging up nursing facilities or hospitals. However, when we say that, we say it with the full realization that there is no standard community-based palliative care program. And we have been just today actually had a conversation with the administration about the need for a community-based palliative care benefit that we could really wrap our arms around, so that when we say to people, don't go to the hospital, stay at home, we can actually bring some care to them in the home. We talk a lot about post-acute care and the need to get individuals linked up with post-acute care providers. What we're talking about here is pre-acute care, so that people don't decline, so that we don't hear the sirens, and so that folks actually get the care where they are without having to decline. This is not something that's unique to COVID-19, but I think COVID-19 shows in a real stark way what the need is. We've also been working on enhancing our capability for the bereavement support. And bereavement support here isn't only for and not only bereavement support, but just support in general, not only for the family of the individual getting care, but also for the community that's broader than the hospice and palliative care community, and in fact other care providers. In many communities, it is the local hospice or community-based palliative care provider that's providing bereavement support to the frontline hospital workers who are dealing with just incredible trauma. So that has to be ramped up as well. And of course, additional flexibilities like the telehealth flexibilities that we've seen so that we can provide more care for more people earlier and ideally in the community. And that has been and will continue to be a focus of our community as well. Next slide, please. So first of all, as I've mentioned before, we've been very careful to work closely with our partners. For example, ACA, which represents nursing homes, and NHPCO worked jointly on a statement surrounding visitation in nursing homes. On the one hand, we are very aware that there are nursing homes that are essentially locked down, where there are just massive numbers of people being infected. We don't want to do anything to first of all demean the nursing homes that are going through this, or to do anything that would contribute to the spread. On the other hand, if you're an individual that's receiving hospice in a nursing home, you should have access to your care provider. That's not a visitor. It's not a family member necessarily. It is a care provider, and just like anybody else, you should have access to it. So we work together with ACA on guidance. First of all, if we don't need to make an in-person visit and we can use technology, we're going to do that. And I talked about telehealth earlier. But second, if individuals actually have a need for an in-person visit, we jointly talked about the rules of the road, working with guidance that CMS has provided about how those visits are to be made. And that's information that's available on the NHPCO website. And at the end of the presentation, I'll show everyone where it is. Next slide, please. So it feels a bit odd to talk about the silver lining of any pandemic, but it's really important for us to think about how innovation sometimes happens in the wake of a catastrophe. And that's certainly true here as we think about the use of technology, for example. What the COVID-19 pandemic has really shown is, in some ways, the gaps that we have in our system. I mean, if you want to think about it, we have a very institutionally driven, very acute-driven, very medically-driven model that relies upon employer-based health insurance. And so all of those things have been upended in the context of people being unemployed and people not necessarily being in institutions to receive care. So one of the reasons why we've been working on a disaster relief community-based palliative care demo is because there is a gray area in between what people might be getting in an institution, say a hospital, and what's available via hospice. A lot of people don't make it out to hospice. They're not eligible for hospice. They may not even be dying, but they certainly have community needs that are currently not being met. So that's one thing that I would call a silver lining, is the ability to really shed a light on some of the inefficiencies and gaps that we have in our current system. I would say, too, bereavement services. It has always been true that we've underfunded and under-accessed, really, bereavement services in the community. You know, every time that there's a natural disaster or a school shooting or anything else that happens, there is trauma. There's a need for grief and bereavement support, and we do need to do a better job as our country at meeting that need. So a silver lining of all of this could be that we really enhance the availability of grief and bereavement support. And then the last thing, which shouldn't be an afterthought at all, is advanced care planning. If one thing that comes out of this is that we realize that we're all immortal, as Atul Gawande said, and that you never know, and that we want to make sure our wishes are known. Otherwise, someone else is going to be making a decision for us. Then COVID-19 will be an impetus for people executing, digitizing, because you don't want to have something in a safe deposit box, and then revisiting their advanced directives. And that's something that we hope will be strengthened coming out of COVID-19, and certainly that we're talking about as well. So it's not all hospice. It's not all palliative care. It's all about the kind of care you want being articulated clearly so that it's actionable. Next slide, please. Right at the very start of this pandemic, at the end of February, early March, we started daily updates for COVID-19. Information is available at NHPCO.org/coronavirus, and we have every day information that goes out relevant to providers, relevant to consumers, relevant to everybody, so that we can be very clear about what opportunities there are out there for additional information. We've been careful to only push out information that we know about. No speculation, just very sort of actionable information. Next slide, please. So, again, NHPCO.org/coronavirus is the place to go for information about what we know, information and resources that we're providing. And with that, I wanted to pause, ask if there are any questions that anybody has about the work that we're doing or about anything else. I'd be happy to engage in that dialogue. And I think you could probably ask it verbally or put it in your chat box, and Jonathan will provide you with that information.
Yes, thank you, Edo. So we can move to questions now, and if you have questions, you can post them in the chat box by rolling your mouse over the screen. You'll see the interface for that pop up if you're on the web, and if you're on the phone, we can start out with some phone questions now. And to ask a question on the phone, you can hit *7 on your phone to unmute your line and ask your question. And it looks like our first question is from Kathy Ray, and she's asking about whether we can provide these resource links that you mentioned in your slide presentation, if we could put those in the chat box. I will try to do that. If not, we will include them with the slides and the other materials when we post all this to our member portal, Member Connect, and I'll have some more details about that at the end. Looks like we also have a question from Karen Carrig. Karen, would you like to ask your question? Karen asks, will NHPCO be advocating for a continuation of telehealth waivers?
That's a good question, Karen. Absolutely. The initial telehealth waivers are during the pandemic, and there are a lot of the waivers that are time limited in the sense that they're only for use during the pandemic. I strongly suspect that at least some of these waivers will be extended, and certainly we're advocating for a number of these waivers, including the telehealth waivers, to be extended. I think the proof is actually going to be in the pudding, in the performance sort of out there. So, if the reason why you want to have in-person visits is that you think that that's going to reduce fraud, or you have a question about quality, but it turns out that in the analysis of the data that the government gets during the pandemic, those things have not increased in the world where we're utilizing telehealth more, then that's going to be a really strong argument for the expanded use of telehealth. For the same reason as, so many of us who run organizations have to strike a careful balance between the use of people being in the office versus sort of virtual work. It may be that gets jumbled up as well, as we all see that virtual work actually works really well. I think the same thing is going to happen with telehealth, and certainly we're watching and we're monitoring, and we'll argue for an expansion of telehealth absolutely beyond the end of the pandemic. Thank you for the question.
All right, and our next question is going to be from John Shaw. John, do you want to ask your question? I see John's trying to come off mute, but he must be having a problem. So I'll ask the question for him. How is end-of-life counseling different if family is not allowed to see their loved one dying in the hospital or nursing home?
It's a really good question. The really unfortunate situation that we're in right now is that hospitals and nursing homes are on virtual lockdown. One of the reasons why I think we need a pre-acute community-based palliative care demo is precisely to prevent people who shouldn't be or don't need to be or don't want to be in the hospital from getting in there to begin with. So I think, number one, I think the advanced care planning conversations and the community-based palliative care benefits should actually precede the hospitalization if at all possible. The questioner brought up a good point, which is what happens if the individual is in the hospital already? How do those conversations defer? And obviously, that's going to be a really good use of technology. And the relaxation of the HIPAA rules will allow, for example, for a FaceTime call between the physician or practitioner at the hospital, the patient, and the patient's family to do a number of things. For one thing, I'm a lawyer, but I think lawyers often overcomplicate the reality of an advanced care planning document. It is legally binding, usually, for someone who has capacity to take their smartphone out and say, "This is who I am. This is what I wish. This is essentially my both healthcare proxy and power of attorney for healthcare," and text that to whomever you want to text it to. That's proof. And so one of the things that I think we'll see in all of this is enhanced use of technology to allow for those advanced care planning conversations to happen and to be executed as well. But again, I think it's much better for it to happen before an individual is in the hospital so that it can be face-to-face and more robust. That's a good question. Thank you.
Edo, as we think about the future evolution of hospice and palliative care and long-term care facilities like nursing homes, do you see what we're experiencing with COVID-19 driving changes in the way that these facilities are even constructed or set up?
Yeah, I think one thing that, nursing homes are not necessarily built, most of them are not necessarily built to deal with people who are highly infectious. Hospice inpatient facilities are, but there aren't as many of them. So, a lot of nursing homes are set up to take post-acute individuals who have knee issues or dementia or various other things that are not infectious in nature. I think we're going to have to pay a lot more attention to the ventilation and a lot of the sort of the facilities issues within the different entities. I also think and this brings up a whole host of other sort of challenges, but if in the context of a highly infectious disease, it may be prudent, and this is happening in a couple of hospice facilities, to have a COVID-19 wing or a COVID-19 building until we get a handle around the infectiousness of a disease or have a vaccine in place. And that is one way to make sure that perhaps individuals with antibodies or individuals who have been infected are kept away from individuals who are not yet infected. So I think it's both in the technology that we use, the the physical plant, and then also where individuals are housed, that I think we're going to want to take a really strong look at the future construction of some of these facilities.
Just one of the many ways I think we're going to see our society shifting, both in terms of the infrastructure as well as how people behave, that things we probably wouldn't have foreseen happening in such a short time frame if it wasn't for this shock to the system.
Yeah, absolutely. And yet I think the shock to the system and some of the changes have been years in the making, and it sometimes takes a shock to kind of tip them over the edge.
Could you also comment on the topic of social isolation? I'm thinking about my mom's cousin. She is in a long-term care facility. Essentially, she just doesn't even really get any exposure to the other residents. And I can remember from experiences with my own mother-in-law, that can get really isolating and be difficult for folks in that situation.
Right.
Can you speak to that challenge and maybe some of the things that you think we'll end up seeing as potential remedies for that?
Yeah, I mean, I think that social isolation is something that predates and has been exacerbated by COVID-19. You have a lot of folks who are either in institutions or at home socially isolated, and right now everybody is socially isolated from everyone else. We talked about technology. Technology only gets you so far. My great Aunt Ruby plays Jeopardy with Alexa every night, and she's still lonely and socially isolated. That's not going to change. So I think we need to figure out what things we can do remotely and virtually, and what things actually do require a human touch. One of the reasons why I think we actually need a community-based palliative care benefit is because the idea of an interdisciplinary team that is available to provide care for folks, and sometimes that care is not medical in nature, it's or even clinical in nature. It's social in nature. Individuals need support from chaplains. They need support from social workers, and there's no mechanism for getting those people to provide that care right now in the community and get paid for providing that care. At least no standard mechanism. So I think that's something that'll be, whether it happens really, really soon as a response to COVID-19, or it happens as we kind of look back to some of the things that we're missing. I see that as being something that grows as we see that it wasn't only COVID-19 that killed people. It was depression. It was substance abuse. It was the trends that we'd already been seeing. And COVID-19 actually just exacerbated that. So more care in the community, figuring out what we can do via technology and what we can't, I think is going to be crucial with this pandemic.
Well, let's go back to the phones and see if we have any questions from the phone lines. I can see from the folks that we have in attendance today that we've definitely got some members of your community out there, and I'm sure that they have thoughts and experiences that they could share with our audience. So I'd like to invite anybody on the phone who has something that they'd like to share to do that, if it's a question or maybe an experience that your organization has had. And remember, you just need to hit *7 on your phone to unmute your line.
Hello, can you hear me?
Yes.
Yes, sir.
Hi, it's John Shaw from Next Wave. I was wondering if you could talk about the whole conflation of hospice and palliative care. I think over time, those in the profession get the difference, but I'm wondering how much of those out in the community do. And with the impact on families and patients who hopefully don't believe they're going to die but are still under major stress in their life, are they eligible for palliative care? And how do we get them to know it, to ask for it?
Right. John, thank you so much for that question. It's a great one. as some of you may know, the term palliative care really kind of came after the hospice benefit as a way to describe the kind of services that people could get, and I think it was coined by a physician up Balfour Mount up in McGill in Canada. You know, the fact is, for most people, they don't think about hospice or palliative care, period, and certainly not until it's too late. And we often make, I think, artificial distinctions between the hospice benefit and palliative care that just serves to confuse people. And most people just need help, and they need help from a variety of different people. And while we have a hospice benefit in the United States, in most of the rest of the world, there is no hospice benefit. There's just a palliative care ability to get palliative care services. And so what I'm describing and what I think we need is a real simplification of serious illness care for folks that allows them to access something. And it doesn't need to be called palliative care. It doesn't need to be called hospice for sure, but it's community-based, interdisciplinary, person-centered care, serious illness care. It's whatever we want to call it, that often precedes or goes in together with a decline that people are experiencing. So one way to think about it in the context of COVID-19 is, as we contract trace, and we see that there are a lot of other people out there who have been exposed to Edo Banach who has COVID-19, and we have some individuals with multiple comorbidities, those are people who are likely in a position where they already need community-based support. And that's what we're talking about. I think we overcomplicate it and over-medicalize it when we say palliative care, because palliative medicine has become a medical specialty. When I say palliative care, I mean I want to get you support in the community for the things that kind of fall in between everything else that exists, the gray area. And I think the way that we get people to ask for it by name, however we name it, is by really describing how this benefit kind of fills in all the gaps of the current healthcare system. And that was tough pre-COVID-19, but now in the context of COVID-19, there's so many ways we can point to individuals quarantining in place, anxious, depressed, hungry, without access to all the things that you need to actually quarantine in place. And what we're talking about here is filling that in with a bundle of benefits that serves to sort of meet those needs. That bundle of benefits is not something that Medicare is in the business of paying for. Ergo, it's not usually provided. Medicaid, more so, depending on the state that people live in. Medicare, not so much. And so I think there's some messaging work that we need to do and communications work that we need to do, but I also think we need to simplify the way that we talk about the care that we want and rely less on the medical jargon and lingo and more on, we're talking about support and care in the community that wraps around the healthcare system. But that's a good question, and certainly I'd love to work with you on others around the right way to describe it.
And a follow-on to that, you mentioned hitting people when they're ready to listen as part of contact tracing.
Yeah.
And I'm wondering if that's included in the training we're giving all of these thousands of contact tracers that are taking their 5-hour course and becoming one.
No, it's not, and it should be.
And so how do we make that happen? Ha-ha!
Well, I think that's going to take the entire NQF community putting their thinking hats on. I think that first we have to stand up the contact tracing infrastructure where it doesn't really exist. And then I think we need to think about how we add on to it. And something fascinating to think about is, what does quality contact tracing look like that really goes beyond the bare minimum? And I would love to work with anyone who is listening on that.
Sounds like a Member Connect dialogue.
Yes, indeed. Thank you so much for the questions.
Thank you.
So thank you, John. We'll go back to the phone and just see if there's any more questions, and if not, we'll wrap up. But we'll give it one more shot to make sure everybody got a chance to ask any questions or make any comments that they had about the presentation today. All right, well, we'll wrap up there. Edo, thank you so much for taking the time to share all this with us today. I definitely learned a lot about this space. John asked the question about the difference between hospice and palliative, and I did not know what the difference was before today. I'm a layperson, so this is informative for me as well. So thank you again for being with us to do this. I'd also like to thank everybody. You're welcome. I'd also like to thank everybody who joined us on the phone today. We hope the information that was shared will be informative for you. And please be on the lookout for a brief survey after today's program. If you could just take 60 seconds to give us your feedback, we would appreciate it. And I encourage everyone to tap into our amazing community of healthcare quality leaders. We have an active conversation underway on our online member portal, Member Connect, and the recording of this program will be posted there in the next day or so. And that concludes our program for today. On behalf of everyone at NQF, we wish you continued good health. Thank you.